temporomandibular joint disorders affect about 33 million Americans and is the second leading cause of disability worldwide, and there is no cure, or at least there's no standard therapy. And this leads to dangerous experimentation, and thousands have been hurt by irreversible therapies, which often result in failure.
Many people suffering from TMJ problems get surgeries and end up doing more harm than good. Now we're learning that some of those patients have out-of-pocket costs that are driving them into debt.
You spent tens of thousands of dollars on these treatments.
Yes.
And at the end of the day, where did they leave you?
I paid for pain.
But experts believe there may be hope. According to a 2020 review, interdisciplinary care may become the future of TMJ care, resulting in success as high as 40%, combining the help of different professionals in dentistry, physiotherapy, pain specialists, massage therapy, and in most recent years, one particular practice is starting to emerge: clinical pain psychology. But how exactly do they fit in the mix?
Pain interferes in people's lives and can cause distress and can prevent them from doing valued activities. And so some of the distress that emerges secondary to having TMD, a psychologist may help people manage that distress. So if they become anxious or depressed or have other impacts on their mental health because they've developed TMD, that can be a role that psychologists can help with.
But none of this is new. The psychology practice has always found relevance in chronic pain care. In fact, that's why the Temporomandibular Disorder Consensus Report specifically has a psychologist on board, indicating that TMJ is closely related to the relationship between pain and its psychological impacts.
One of the things that became clear from the Institute of Medicine report is that pain is among the most expensive and most prevalent public health conditions in the United States, and that our healthcare providers are not receiving adequate training to manage this problem effectively.
So with that being said, apart from being knowledgeable about the theory, what do clinical pain psychologists actually do?
A related role, but somewhat separate, is teaching people skills that they can use to cope with the pain itself. Some of these skills can directly reduce the pain, which is obviously helpful. If you have less pain, then there may be less interference in your life and less impact on your mental health and functioning. And so there are pain coping skills, for example, relaxation strategies, mindfulness meditation strategies, other specific behavioral changes that people can make that will, as a direct result, potentially lower the amount of pain someone is suffering. When people are experiencing pain, they often are less interested in being around other people. Let's say you've got a work function to go to, and your partner has TMD pain, and you'd like them to join you, and they're in too much pain to join you at the function. And so either you stay home and spend more time together, or you go by yourself. And so it can interfere with the ability to do enjoyable social activities like that. If you're in pain and it's impacting your mood and you're more depressed or more anxious, that will interfere with the enjoyment that you can have with other important people in your life. And then the other challenge that emerges for family members, friends, people in the life of someone with temporomandibular disorder is they don't know how to help. Right? What am I supposed to do for you? Should I, massage your jaw? Should I ignore your pain? Should I express sympathy? Should I provide support? Because people don't always know what to do, the partners, the family members of people with TMD pain may themselves withdraw. There may be sort of interference in the connection in that way, if that makes any sense. The way we conceptualize pain, I think, has evolved significantly since I've been in the field. When I came into the field, I would say the prevailing model was the biomedical model of pain, and it is still quite influential, but it's not the only game in town anymore. And the biomedical model of pain says that there must be an underlying biomedical disruption, tissue damage, some kind of derangement of the joint, something like that. And that's what's causing your pain. We're going to look and find out what that root cause is in your biology or in your anatomy. We're going to try to fix that, and then your pain will get better. Occasionally, that works. Unfortunately, it doesn't work in many cases, and it fails to recognize the complexity of pain, no matter what the originating cause of the pain is. It has also led to harm in that many surgeries have been done. TMJ implants have been placed that ended up, rather than helping people, causing harm to people. And so this more simplistic view of pain, and it's not just TMJ pain where this view abounds, it's chronic pain in general, has not provided substantial relief to people suffering from pain. However, in the last 20 years, there's been a greater and greater appreciation and adoption of what we refer to as the biopsychosocial model of pain. That is the recognition that in every instance, not just in TMJ pain, and frankly, not just in chronic pain, but in every instance, the experience of pain is driven by interactions between biological, psychological, and social factors. And that if you're not trying to incorporate all of those factors into understanding a person's pain, you're going to fall short. You're going to have an incomplete understanding of their pain.